Hello, my name is Stefan Stiegenbauer. I'm Professor of Medicine at Ulm University in Ulm, Germany. The focus of my work is understanding biology of CLL and developing new treatment approaches. In the following lecture, I would like to discuss with you the initial approach to CLL patients, their workup, and the management with regard to frontline treatment. Chronic lymphocytic leukemia, CLL, is the most common leukemia in adults. The diagnosis is usually straightforward from peripheral blood. It requires a clonal lymphocytosis of greater than 5 per nanoliter with a characteristic immunophenotype, usually CD19, CD5, CD23 positive. The molecular pathogenesis of the disease is complex. We know that the microenvironment, B-cell receptor and other cell surface receptor signaling, genomic abnormalities, mutations, and epigenetics play a role. From a clinical perspective, it is striking that the course of the disease is highly variable. The survival times of individual patients range from months up to decades. Also, we today have a wide range of treatment options available, ranging from watch and wait up to allogeneic stem cell transplantation. CLL over the recent years has served as a model system for therapeutic developments, targeting for instance CD20, BCL2, BTK, PI3K, or for the development of CAR T cells. This cartoon highlights key pathogenic features of CLL, such as B-cell receptor signaling, such as deregulated apoptosis, and the interaction with the microenvironment. And all of these features today serve as tools for therapeutic approaches. Now, over the recent years, a wealth of prognostic parameters and novel treatment options have developed. However, only few of those are relevant for routine clinical practice. The mainstay of clinical decision-making and prognostication remain the staging systems developed by Jacques-Louis Binet and Kanti Rai. As an example, here the Binet staging system is given that distinguishes between 3 stages A, B, and C, defined only by physical examination, looking at lymph nodes, liver and spleen, and a simple blood count. Binet stage A is defined by the involvement of less than 3 regions, hemoglobin above 10 and platelets above 100. Binet stage B is defined by 3 or more involved regions, and Binet stage C is defined by hemoglobin less than 10 and or platelets less than 100. Of note, imaging techniques are not relevant for the Binet staging system. The gold standard for managing CLL is outlined by the IWCLL guidelines. Among the tests for pre-treatment evaluation of our patients that are desirable not only in clinical trials but also in general practice is, among the physical exam and the usual workup of the patient, the cytogenetic testing, in particular for deletion 17p. The updated guidelines are currently in preparations and will include TP53 mutation testing in addition to 17p testing before the initiation of treatment. Now, what are the critical questions in upfront CLL management? The vast majority of patients, around 80% today, are diagnosed with early stage disease. And in those patients, obviously, the key question is, when will there be disease progression and potentially treatment requirement? There was a large trial performed by the German CLL study group, the CLL-1 trial, that performed in Binet stage A patient, now with a long follow-up of over than 8 years, a multivariable analysis of a wealth of potential prognostic markers on a large cohort of over 500 patients. In the table below, you see summarized for overall survival and progression-free survival the independent prognostic parameters. Those include a 17p deletion, 11q deletion, unmutated IGHV, short lymphocyte doubling time, more than 1 enlarged nodal site, and beta-2 microglobulin. For overall survival, in addition, age, and for progression-free survival, in addition to that, blood parameters such as ALC and hemoglobin level were of independent prognostic significance. This slide highlights from the same data set the importance of a single prognostic marker, namely the IGHV mutation status. On the left, you see that for progression-free survival, and on the right for overall survival, this single parameter identifies patients with rapid disease progression and short overall survival, even when diagnosed with early-stage disease. Nevertheless, treatment of early-stage patients remains watch and wait as the standard of care. This is based on data published a long time ago with chlorambucil treatment from the French group. In this trial, early-stage patients were randomized to either no therapy or chlorambucil treatment, and you see that with regard to overall survival with a long follow-up, there was no significant difference with regard to early initiation of chlorambucil therapy. Now later, the German CLL study group together with the French group performed the CLL7 trial. The data in a preliminary analysis is shown on the right panel. Here, low-risk patients received the watch and wait strategy, and only high-risk patients were randomized to either FCR or to a watch and wait strategy. And you see when you're comparing the two curves with regard to overall survival, there is no significant difference and no clinically meaningful difference in outcome. Therefore, even in the era of FCR treatment, watch and wait remains the standard of care for early-stage patients. Now, once the disease has advanced and there's active disease according to the IWCLL criteria, obviously the important question is, will there be a response to treatment and how long will that last? Response to treatment has evolved quite a bit over time. This slide summarizes the response rate given as overall response and complete response when comparing treatment with chlorambucil, fludarabine plus cyclophosphamide, and FC plus rituximab, the FCR regimen. You see that overall response approached almost 100% with FCR, with a complete response rate close to 50%. This slide looks at a historical comparison of overall survival between different patient cohorts at the MD Anderson Cancer Center in Houston, Texas, where the FCR regimen was pioneered. You see that in this historical comparison, FCR, the orange curve, for the first time appeared to significantly improve overall survival when chosen as a frontline treatment. The similar was analyzed in the German CLL study group CLL8 trial, a large trial on an international basis that enrolled patients with advanced stage CLL for frontline treatment, comparing fludarabine and cyclophosphamide FC against FC with the addition of the CD20 antibody rituximab, the FCR regimen. This trial met its primary endpoint in the sense that progression-free survival was significantly improved, but more importantly, and as shown in the right panel, FCR also improved overall survival with a hazard ratio of 0.68 at a median follow-up time of 5.9 years. This was the first time that in a randomized comparison of frontline treatment in CLL, the choice of a specific treatment, here FCR, improved overall survival. Therefore, FCR was set as the new standard of care for young, fit CLL patients requiring treatment. On the other hand, all treatments have their side effects. This is looking at the adverse event profile of grade 3 and 4, comparing FC on the left and FCR on the right. You see that in particular hematologic toxicity, in particular neutropenia, is increased when comparing FCR against FC. Correspondingly, the rate of severe infections is also increased when comparing FCR to FC. Also, this value did not meet statistical significance. Treatment-related mortality was 2% for both treatment arms. Now, other factors that influence outcome in CLL8 trial, but also in other trials of similar kind, are genomic abnormalities shown on the left and TP53 mutation status shown on the right. The left panel compares progression-free survival, color-coded for the dominant genomic subgroups of the disease, and again comparing the two treatment options, FC or FCR, in the broken or solid lines. You see that, for instance, for patients with an 11q deletion, the green curves, the outcome when comparing FC against FCR is dramatically improved by the latter. On the other hand, when you focus on the two black curves, the patients with a 17p deletion, you see that their progression-free survival is very short, with a median met at about 12 months only, and there is no significant difference neither when treated with FC nor when treated with FCR. Similarly, when looking at TP53 mutations on the right, you see that patients with a wild-type TP53 status, the green curve, have much better outcome as compared to patients with mutated TP53. Again, the treatment method among patients with wild-type TP53 in the sense that FCR dramatically improved outcome as compared to FC. On the other hand, for the patients shown in blue with mutated TP53 status, progression-free survival was not much different, clinically not meaningfully different when comparing FC against FCR, therefore showing again that for patients with a 17p deletion and or a TP53 mutation, treatment with FCR is not a satisfactory choice. Now, prognostic markers are obviously nice to have. They tell us that outcome of a patient may be better or worse, irrespective of treatment. However, what we really like to have in oncology are predictive markers. Markers that tell us if one treatment or the other is of particular benefit for an individual patient. To that end, we performed a formal predictive marker analysis on the same data set. We performed a multivariable Cox regression, including treatment interaction. The outcome of this analysis was that FCR held its significant benefit. TP53 mutation was again identified as an adverse marker, as was SF3B1 mutation, and the only treatment interaction that we identified was the interaction between Notch1 mutation status and treatment. Now, what does that mean in a more graphical presentation? When looking at patients with Notch1 wild-type status, so without a mutation in the Notch1 gene, we see that FCR indeed shows the expected benefit with regard to progression-free survival, median 57 months versus 33 with FC. Now, when comparing to that patients with a Notch1 mutation, we don't see a benefit when comparing FCR against FC whatsoever. Median progression-free survival is exactly identical and very similar to what we saw with FC in the Notch1 wild-type patients. Therefore, the addition of rituximab appears not to benefit patients with a Notch1 mutation in their CLL cells. In other words, Notch1 mutation status is a predictive marker with regard to treatment choice of chemotherapy versus chemotherapy plus rituximab. This is obviously a provocative finding, so far fully published only from a single trial, and therefore in need of confirmation from other trials, but this finding may inform treatment choice in the future era. Now, this has shown the impact of a single mutation on outcome. What is obviously even more interesting is to analyze the whole genome of CLL. To that end, we performed whole exome sequencing to characterize the mutanome of CLL cancer driver mutations in a large cohort of patients of over 538. Notably, 44 cancer driver mutations were identified in total in that dataset, and almost 70% of patients had at least one cancer driver mutation. The most common abnormalities, as shown in this panel, were mutations in SF3B1, in ATM, TP53, POT1, Notch1, XPO1, and BRCA3. You see, however, that there was a large number of mutations that occurred at very low frequency and obviously did not define large patient subgroups. Fortunately, however, when grouping these abnormalities into prominent cancer driver pathways, only a few of those pathways appeared to be recurrently affected by these mutations, highlighted in red and purple in this cartoon. Among these, obviously, pathways that are today of therapeutic relevance, such as B-cell receptor signaling, and pathways that are of importance with regard to chemotherapy, such as DNA damage and cell cycle control. Now, from a clinical perspective, obviously it is interesting to see what these mutations mean for clinical outcome. In the left panel, you see an analysis by the Spanish ICGC consortium that shows that with regard to time to treatment and also overall survival, the number of drivers found in the CLL cell is of impact. On the right, you again see the whole exome data set on the CLL-8 trial, where the impact of BRCA3 mutation on progression-free survival was studied, and in contrast to previous analyses outside clinical trials, there was no significant impact of BRCA3 mutation on outcome whatsoever. This obviously points to the note of caution that is important when looking at the identification of prognostic markers and the importance to confirm the impact of these prognostic markers in the context of well-designed prospective clinical trials. Now, CLL-8 showed that FCR is better with regard to efficacy than FC, but on the other hand, it also has its downsides, in particular its adverse event profile, and FCR is obviously not a treatment that is possible in the vast majority of elderly patients with CLL who have a large degree of comorbidities. Therefore, the German CLL study group in their next trial, CLL-10, tested if FCR could be replaced by bendamustine plus rituximab, the BR regimen, and this was tested among fit patients without a 17p deletion and in good physical fitness. These patients were randomized 1-to-1 between FCR and BR. Now, the results that were published last year by Barbara Eichhorst in Lancet Oncology showed that for patients younger than 65 years, FCR indeed had a statistically significant and clinically meaningful benefit with regard to progression-free survival. However, among patients older than 65 years, there was no significant difference and there was no clinically meaningful difference between the two curves. In addition to that, overall survival between BR and FCR treatment in that trial was not significantly different. What was different, however, was the incidence of more severe side effects. This table summarizes the grade 3 and 4 AEs in CLL-10. You see that with a longer observation time that was used in that trial, you see indeed a high rate of grade 3-4 neutropenia with FCR, much higher than with BR. You see that infections occurred in 39.1% with FCR and 26.8% with BR. Treatment-related mortality was fortunately low, but nevertheless 4.6% with FCR and only 2.1% with BR. Overall, taken together, this indicates that BR is indeed a better tolerated treatment, and together with the fact that progression-free survival was not significantly prolonged in elderly patients, the conclusion here was that BR is a very valid treatment alternative for fit patients over the age of 65 years in need of frontline treatment. So the most relevant CLL chemotherapy issues are 17p deletion and TP53 mutation, i.e. resistant disease, and comorbidity, or as another surrogate for that, the age. Therefore, in these two patient groups, we need further developments beyond FCR and BR. To that end, the GSK Complement 1 trial was performed in patients particularly ineligible for fludarabine-based therapy. These patients in need of frontline treatment were randomized 1-to-1 between the standard of care at that time, namely chlorambucil monotherapy, or chlorambucil with the addition of CD20 antibody ofatumumab. The important outcome of that trial was that the addition of ofatumumab to chlorambucil significantly prolonged progression-free survival with a hazard ratio of 0.57 and a highly significant p-value. The median follow-up of that trial was 28.9 months when published, and the median progression-free survival of ofatumumab chlorambucil treated patients was almost 24 months, almost doubling the progression-free survival as compared to chlorambucil monotherapy. A very similar trial was performed by the German CLL study group, the CLL-11 trial, again for first-line treatment of patients with comorbidity. This trial compared in a 3-arm design chlorambucil monotherapy against chlorambucil plus rituximab, against chlorambucil plus the novel CD20 antibody GO101, or today obinutuzumab. When comparing the adverse event profile of patients treated with GO101 chlorambucil versus rituximab chlorambucil, you see that there's a higher rate of adverse event overall. In particular, infusion-related reactions are more pronounced with GO101 chlorambucil, as is neutropenia. However, fortunately, the rate of infections was not significantly different when comparing the 2 arms against each other. On the other hand, when looking at efficacy, the primary endpoint of the trial was progression-free survival. GO101 or obinutuzumab chlorambucil resulted into a significantly prolonged progression-free survival as compared to rituximab chlorambucil in the light blue curve. Again, progression-free survival was almost doubled. The hazard ratio was 0.39 with a highly significant p-value. These 2 trials taken together established chemoimmunotherapy with chlorambucil as a chemotherapy backbone and the addition of either ofatumumab or obinutuzumab as a CD20 antibody as the new standard of care for elderly unfit patients with CLL. Now obviously, over the recent years beyond chemoimmunotherapy, there was a marked development of novel agents targeting disease biology, and the question in particular in frontline management today is, should we use these agents, yes or no, and in what subgroups should we use these? We have understood more and more about the biology of the CLL cell, as indicated previously, B-cell receptor signaling, apoptosis dysregulation, and the interaction with the microenvironment. In addition to chemotherapy, that by and large acts through its DNA damaging properties, over the recent years we've seen the development of a wealth of agents targeting disease biology, and some of these agents, such as obinutuzumab, idelalisib, ibrutinib, and venetoclax, have already been licensed for the treatment of CLL. Now, a very prominent target in B-cell malignancies in general, and in CLL in particular, is B-cell receptor signaling, and here in particular PI3 kinase, targeted by idelalisib, and Bruton's tyrosine kinase, BTK, targeted by ibrutinib and similar agents. These molecules are of critical importance in the B-cell receptor signaling, and as B-cell receptor signaling is important for disease pathogenesis and progression in general, obviously it was tempting to speculate that these agents could dramatically change the course of the disease. The first agent under study was idelalisib, and this was studied in Gilead's 116 trial, a trial that among heavily pretreated relapsed refractory patients who did not have any alternative treatment choice anymore available, compared in a randomized comparison rituximab monotherapy against rituximab with the addition of idelalisib. Of note, upon blinded independent review, there was an opportunity of crossover so that all patients could receive idelalisib as a treatment. When the trial was initially published and idelalisib was licensed, the median follow-up of the patients was quite short. But in preliminary form, an update of this data with a 12-year median follow-up time has been published. This update, presented at ASH 2014 by Jeff Sharman, showed a dramatic improvement of progression-free survival when comparing idelalisib plus rituximab, the blue curve, versus rituximab monotherapy treatment, the red curve. Idelalisib plus rituximab prolonged the progression-free survival in this heavily pretreated, relapsed refractory patient population to 19.4 months as compared to 7.3 months for rituximab monotherapy. This data has led to the approval of idelalisib plus rituximab for relapsed refractory CLL, and also, somewhat limited in the meantime, for the frontline use in 17p- and TP53 mutated CLL. Now, why was that limited recently? With longer follow-up in particular, it was noted that idelalisib plus rituximab resulted in quite severe side effects. Among the side effects noted early were higher grades of diarrhea and colitis, But also a higher rate of infections was observed in these patients. Also recently, in frontline use of idelalisib combined with other agents, there was a high rate of pneumocystis pneumonia and CMV reactivation that led to a note of caution when using this agent. CMV monitoring and prophylaxis against pneumocystis pneumonia is recommended when instituting treatment with idelalisib plus rituximab based on these data. Now, an important subgroup comparison of the same trial showed that rituximab idelalisib has efficacy also in genetic high-risk CLL. The left panel compares patients with unmutated and mutated IGHV genes, and you see that the outcome is not different whatsoever when treated with rituximab idelalisib. Now, more importantly, even on the right panel, you see the same comparison looking at 17p deletion and TP53 mutation. Again, you see when treated with rituximab idelalisib, outcome of patients with 17p deletion or TP53 mutation is not different as compared to patients without these abnormalities. In other words, these data indicate that rituximab idelalisib is an efficacious treatment irrespective of the presence or absence of 17p deletion and or TP53 mutation. Now, the other agent licensed for use in CLL, first in the relapsed refractory setting, is ibrutinib, a BTK inhibitor. The license in relapsed refractory setting was based on the phase 3 RESONATE trial that compared oral ibrutinib single agent against IV ofatumumab treatment in a heavily pretreated advanced stage patient population that was ineligible for purine analog-based chemoimmunotherapy, either based on a short progression-free survival upon prior therapy, or based on advanced age, or based on the presence of a 17p deletion. That trial showed a dramatic improvement with regard to progression-free survival when comparing ibrutinib against ofatumumab with a hazard ratio of 0.215 and a highly significant p-value. Another trial that contributed to the development of ibrutinib was the RESONATE 17 trial. This trial looked at a particularly well-defined high-risk patient population that was uniformly characterized by the presence of a 17p deletion and relapsed refractory disease with at least one line of prior therapy. 144 patients were accrued to the single-arm trial, and the primary endpoint was overall response rate. Ibrutinib monotherapy in this trial resulted into a very impressive progression-free survival. When comparing this progression-free survival against historical chemoimmunotherapy controls, a very striking finding can be seen. Progression-free survival with ibrutinib at 12 months is about 80%, while at the same time point, progression-free survival with chemoimmunotherapy, even in the frontline setting, is less than 50%. We have to note that patients on the ibrutinib trial had a median of 2 prior therapies. In other words, outcome of these patients with ibrutinib is dramatically improved even if they had heavy prior therapy as compared to what we have seen with chemoimmunotherapy in the frontline setting. And these data have supported the license of ibrutinib in the frontline treatment of CLL with a 17p deletion and or TP53 mutation. Now, the next step was taken with the RESONATE 2 trial that compared among treatment-naive CLL patients of advanced age and who could not be treated with chemoimmunotherapy such as FCR, a treatment with ibrutinib monotherapy against chlorambucil. Of note, upon independent review committee confirmed disease progression, a crossover from the chlorambucil arm to the ibrutinib arm could be performed. This trial was fully published by Jan Burger and colleagues in the New England Journal, and an update was presented at the ASH meeting in December 2016, now with a 29-month median follow-up time. The patient characteristics in this trial were reflective of the usual CLL population, with an advanced age, decreased performance status in quite a proportion of patients, advanced RISE stage, high SEER score, and decreased renal function in many patients. Other disease characteristics, such as 11q deletion, were also quite prevalent. In this population, ibrutinib resulted into a dramatic improvement of progression-free survival as compared to chlorambucil monotherapy, with a hazard ratio of 0.12 and a highly significant p-value. Despite the opportunity of crossover, also overall survival was improved with ibrutinib treatment, making the point that the choice of first-line treatment is of importance when it comes to long-term outcome. These data have led to the approval of ibrutinib in the frontline setting for all CLL patients requiring therapy. Obviously, next to efficacy, also the side effect profile of an agent are of importance, and here it is rewarding to see that ibrutinib is not only very efficacious but also very well tolerated. This slide summarizes the most prevalent AEs in the ibrutinib arm. You see that low-grade diarrhea, mostly occurring early during treatment, is the most common abnormality, next to fatigue, cough, and some degree of hematologic toxicity. On the other hand, and very rewardingly, infections, for instance represented by pyrexia, are very uncommon. When you look at higher grade side effects, grade 3 and higher, you see that the numbers are very small and that only a minority of patients develop high-grade hematologic toxicity or infections with ibrutinib treatment. Of note, a number of new adverse events emerge with these novel agents. With ibrutinib, for instance, hemorrhage can be counted, mostly mild hemorrhage, but a number of patients, 7% here in this trial, developed major hemorrhage. Another novel side effect that we see with ibrutinib is atrial fibrillation that occurred in 10% of ibrutinib-treated patients. Now, with longer-term treatment, and we know that ibrutinib is a long-term treatment, it is important to check if the side effect profile is not changing. Again, here the AEs comparing the first year of treatment were compared to the second year and to the third year, and it is rewarding to see that side effects such as neutropenia did not increase over time, as did infections. Hypertension and atrial fibrillation occurred also predominantly early in the treatment, although obviously with a longer follow-up the rate of atrial fibrillation still needs to be watched. Now, not all patients benefit forever from ibrutinib treatment, and mechanisms of resistance to this targeted agent are obviously of great interest. To that end, we were able to identify resistance mechanisms by performing whole exome sequencing on samples comparing baseline sample versus relapse sample. Now, among 6 patients who were initially studied by that approach, the remarkable finding was made that there is a specific mutation in BTK targeting the cysteine in position 481, the target of ibrutinib, and this was recurrently found among almost all of these patients. This cysteine changes the amino acid in the binding position to a serine that abrogates covalent binding of ibrutinib. Another mutation in PLC gamma 2 was found also in this population, and when looking at the pathway in that BTK is involved, it is interesting to see that PLC gamma 2 is the immediate next downstream signaling molecule after BTK. So in essence, the C481S BTK mutation prevents covalent binding but leaves BTK functional, and due to the only competitive inhibition of BTK leads to a lack of efficacy. In parallel to that, the PLC gamma 2 mutation leads to hypermorphic activation of downstream signaling after a BTK, and therefore again activates the pathway despite the presence of ibrutinib to shut down that pathway. These findings, made in a small number of patients who progress on ibrutinib with CLL, underline the importance of the B-cell receptor signaling pathway and the importance of BTK as a bona fide treatment target of ibrutinib. These findings also underline the need to develop novel agents that can overcome resistance to this treatment with ibrutinib. A novel treatment paradigm recently licensed is venetoclax, a novel BCL2 antagonist. Venetoclax touches the delicate balance that is present on the mitochondria with the presence of pro- and anti-apoptotic players of the BCL2 family, and tipping this delicate balance of highly charged mitochondria with pro- and anti-apoptotic molecules leads to dramatic treatment effects in CLL. These treatment effects are so dramatic that in initial trials, tumor lysis syndrome, due to very brisk tumor cell reduction, led to renal problems and sometimes even deaths. Based on these findings, a very dedicated slow ramp-up scheme was developed to institute venetoclax treatment. Dosing begins with a 20 milligram dose for a week that is then slowly increased to 50, 100, 200 and 400 milligrams. And it is interesting to see that with an agent that is used in 5% of its target dose, only 20 milligrams, already marked tumor cell reductions can be seen in patients. This agent needs to be handled with care. IV hydration and allopurinol, in some patients even respiricase, are required to prevent the risk of tumor lysis syndrome, and laboratory monitoring 6 to 8 hours and 24 hours after 20 milligram and 50 milligram and even subsequent dose increases is useful and recommended in clinical practice. Now, the first-in-human phase 1 trial published by Andrew Roberts in the New England Journal showed dramatic efficacy of this agent already in a phase 1 dose escalation trial. Progression-free survival in a high-risk patient population was very long, and there was not a significant difference when comparing patients with or without a 17p deletion, already indicating that this agent may also be active in patients with a 17p deletion. The pivotal trial for licensing of venetoclax was again focusing on this well-defined, very high-risk group of patients with relapsed refractory CLL, all characterized by the 17p deletion. The patient characteristics of this cohort were a relatively high median age and a median of 2 prior therapies, in addition to the presence of a 17p deletion in all of those patients. The response to venetoclax in this high-risk patient population was very dramatic. The median time to response was only 0.8 months, and the response rate approached 80%. The median time to complete response was longer, but probably also due to the short follow-up not fully reached. Progression-free and overall survival, again at a 12-month estimate, are very rewarding, with a progression-free survival of 72% and an overall survival of 86.7%. Clearly very promising results in this high-risk patient population. On the other hand, treatment was well tolerated. Adverse events of special interest were grade 3 and 4 neutropenia in 40% of patients, although we have to remember that quite a number of patients entered that trial already with baseline neutropenia, and all neutropenias were manageable with dose interruptions or reductions and antibiotics. No patient had to stop treatment permanently due to neutropenia. Infections occurred in 72% of any grade, but only in 20% of patients they were grade 3 and higher, so data quite comparable to what we see with chemoimmunotherapy in the frontline setting. Reassuringly, the most common infections were the usual ones, such as respiratory tract infections and urinary tract infections, and not a peculiar infection disease profile was encountered in that trial. Tumor lysis syndrome was manageable with dedicated ramp-up and laboratory analyses, and there were only 2 dose interruptions of 1 day each due to clinically not relevant laboratory tumor lysis syndrome. Of note, no clinically relevant TLS event occurred. Now, another important trial not fully published yet, but presented at the ASH meeting in December 2016 by Jeff Jones, was studying venetoclax in the particularly difficult to treat patient population with relapsed refractory CLL who failed ibrutinib or idelalisib treatment. This was a phase 2 study looking in arm A, in particular at patients who were relapsed or refractory to ibrutinib, and in arm B, who were relapsed or refractory to idelalisib, so patients who clearly failed the usually available treatment options all. The inclusion criteria of the trial were quite liberal, allowing very low counts and even allowing allogeneic transplantation if that was passed longer than a year. Patient characteristics of the trial, again, advanced age, high proportion of unmutated IGHV status, high number of patients with a 17p deletion, and a high number of prior therapies with a median of 4, for instance, in the ibrutinib arm. Of note, quite a number of those patients were not only refractory to ibrutinib or idelalisib, but had failed both of these agents already. In the light of this very high-risk patient profile, the response seen in this trial is very, very promising, with an overall response rate of 70% in the ibrutinib arm and 62% in the idelalisib arm. This data appears to be durable when looking at the duration of response and progression-free survival as shown on the right. The estimated 12-month PFS rate for all patients was 80%, indicating that venetoclax appears to be a valid treatment option for the patients failing ibrutinib or idelalisib, and this data has led to the licensing of venetoclax, at least by the EMA, not only for 17p- and TP53 mutated CLL in the relapsed refractory setting, but also for patients who failed chemoimmunotherapy and failed treatment with a B-cell receptor signaling antagonist. Now, the side effect profile again of venetoclax in this trial of heavily pretreated patients was very favorable. Neutropenia of higher grade occurred in a proportion of patients, which is actually not surprising given the heavy prior therapy of the patients, but the rate of infections, in particular severe infections such as febrile neutropenia and pneumonia, was low. Also, again, no clinically relevant tumor lysis syndrome was observed, and only one patient with a high tumor load met the Howard-Bishop criteria for laboratory tumor lysis. Again, it needs to be stressed then that when starting venetoclax in patients with a high tumor load, obviously precautions such as hydration and allopurinol are required. Now, against this background of the novel agents, what is the role of allogeneic stem cell transplantation? As stated in this EBMT position paper published by Peter Träger and colleagues, in the frontline setting of CLL treatment, even in the very high-risk patients characterized by 17p deletion and or TP53 mutation, no standard role is seen anymore for allogeneic transplant, and only in patients with relapsed refractory disease who have received novel agents, a role of allogeneic transplantation can be discussed. In particular, if patients had failed one of the novel agents already, allogeneic hematopoietic stem cell transplantation can be considered as a treatment option. However, when patients respond to novel agents, obviously the question comes, do we continue treatment with that novel agent, or do we proceed to allogeneic stem cell transplantation as a consolidation options? And factors that need to be taken into account and that can help decision making in this patient population are summarized below. In general, due to the availability of ibrutinib, of idelalisib, and now also venetoclax, the role of allogeneic stem cell transplantation, even in relapsed refractory CLL, has been decreasing over the recent years. And only when a patient fails at least one of those agents, the role of an allogeneic transplant in the further management should be discussed with the patient. Now, in summary, looking at the upfront CLL patient management in a brief outline. Early stage asymptomatic patients all should be observed. Only when advanced stage and symptomatic disease, active disease, according to IWCLL criteria is met, a number of questions arise. The first question is regarding fitness of the patient or age. For fit patients without a 17p deletion and or TP53 mutation and less than 65 years of age, FCR clearly is the standard of care. And among patients above the age of 65, BR can be considered as a valid alternative. Patients who achieve a remission are obviously followed up, while patients failing this treatment need to be considered for second-line therapy. Now, among fit patients with a 17p deletion and or a TP53 mutation, the treatment of choice in the frontline setting is ibrutinib. Venetoclax and rituximab combined with idelalisib are alternatives if patients are not feasible candidates for ibrutinib treatment. Now, among unfit patients, a similar question arises. If there is no 17p deletion and no TP53 mutation, frontline treatment choices of similar validity could be ibrutinib, could be obinutuzumab chlorambucil, could be ofatumumab chlorambucil, and with a little bit less of evidence, bendamustine combined with rituximab. If again 17p deletion and or TP53 mutation is present, the treatment of choice in the frontline setting is ibrutinib, and again venetoclax or rituximab idelalisib are alternative possibilities in case ibrutinib is not a feasible option. Now, for patients who are frail or very old, where in the past best supportive care was the only opportunity, today on an individual patient basis, discussion should occur if ibrutinib or potentially even, but with less evidence, CD20 antibody monotherapy could be of benefit for the patient. Now, summing up, some frontline CLL management key conclusions. Watch and wait remains the standard of care in asymptomatic early stage IE-BNA patients. FCR is the benchmark first-line therapy for young and fit patients meeting active disease criteria of the IWCLL guidelines and who don't have a 17p deletion and or TP53 mutation. Bendamustine rituximab can be considered as an alternative to FCR in fit patients over the age of 65 years. Ibrutinib or chlorambucil plus obinutuzumab or chlorambucil plus ofatumumab or with less good evidence BR are standards for unfit patients without 17p deletion and or TP53 mutation. Ibrutinib with the possible alternatives of venetoclax or rituximab idelalisib are standard for patients meeting active disease criteria and harboring a 17p deletion and or TP53 mutation in their CLL cells. Future chemotherapy-free or reduced combinations involving those novel agents are likely to change the current management paradigm of our patients. Obviously, this still is a clinical research question analyzed in clinical trials and not to be tested in routine practice. With this bright perspective looking over the Ulm Cathedral to the Alps, I would like to conclude this lecture stating that the novel era of targeted therapy offers bright perspectives for our patients. Thank you very much for your attention. I hope you enjoyed the lecture, and I'm looking forward to further discussion with you either on the electronic forum or in person.